welcome. I am Dr. Glenn Mitchell. I am the president of our Central Pennsylvania HIMSS chapter, and I'm the vice provost at Harrisburg University in Harrisburg, where I'm also professor of healthcare informatics. Well, welcome to our Central Pennsylvania chapter of HIMSS webinar, and today we're going to focus on telemedicine. Our guest today is Salim Saiyed, MD, who is a Vice President and System Chief Medical Information Officer at UPMC Pinnacle here in Harrisburg, and a member of our Central Pennsylvania HIMSS chapter board as well. So welcome, Salim.
Thank you, Glenn. Thank you for the introduction, and I'm delighted to be here and talk about telemedicine. Really exciting things happening right now during the COVID crisis on telemedicine.
Well, telemedicine is very much in the news today, especially due to its use in COVID. Many hospitals and providers have been using this set of tools for years now. But today, I want to take a look at the technology and its impact on patients and the practice of medicine, especially in this environment. I hope you're ready for a few questions.
I am, and definitely to your point of news, I was just on a webinar and they were mentioning there have been over 100 stories just in past few weeks across on telemedicine, from Wall Street to Bloomberg to CNN, and I'm sure you guys have seen those. So again, really exciting times.
Yes, they are. You know, we hear the terms telehealth and telemedicine in the news, and many of us are probably a little unsure about their practical definitions. Like, how are they defined, and is there any real difference between those two things?
Yeah, so if you look at sort of practical point of view, there are slight differences. So telemedicine is sort of delivery of medicine at distance by a physician who's in one location and a patient who's at other location. And telehealth refers to sort of the broad spectrum of electronic and technology sort of services that are used to deliver care. It could be store forward, it could be remote monitoring, it could be sort of FaceTiming, video visits. So all of that sort of falls under the telehealth umbrella. Now we use it, you know, quite frequently, one or the other interchangeably in real life sort of practical experience.
Okay, thank you. What are the biggest technical hurdles to a telemedicine program in hospitals and maybe even provider offices today?
So technology has, of course, advanced a lot since, you know, probably just a couple of years ago. A lot of us are getting comfortable sort of FaceTiming, just a consumer technology, right? FaceTiming, Skype, Facebook, all sort of social media apps. So that has helped sort of propel the use of telemedicine a little bit more as well, not just from provider side, but also the consumer side. There are sort of challenges in terms of it can be sometimes new for patients as well as providers. We do have to comply with HIPAA. At least during this crisis, there are some relaxation of those rules and regs, but before that we still had to use secure platforms, and that can be sometimes challenging, just like any introduction of any new technology or new platform is to healthcare or any other industry.
Is it more technically difficult, such that an individual provider would have trouble using this from his or her office? Is it only a hospital system kind of technology, or how can is it effective from the provider's desk, for instance?
It really is. We try to make it as seamless as possible for our providers. So the couple of examples that you gave, they can definitely use it in the hospitals. They can use it in their clinics. And with our current crisis, where we've had several upper providers getting quarantined, and or if they're high risk and they cannot come to work or get exposed themselves, they can use it from home. They can use their personal devices. These are, great smartphones. It's mini computer, has microphone, camera on it, and they don't even almost sometimes need a laptop. They can use their phones to deliver the care they need. So it's quite the broad spectrum, and we try to make it as seamless as possible, that can be used anywhere.
Great. Do you need a lot of training to use telemedicine?
You don't need a lot of training, but we insist on getting some training. We have been able to deliver training virtually as well as telemedicine, so we try to deliver it online, virtually instead of person. And some of it is not just the training on technology. A lot of it is on website manners. A lot of it is on how to show empathy over this platform, how to show empathy to patients right now during this crisis, billing aspects, how to document. There are a lot of rules and regs for different insurance companies on how to document a telemedicine visit. So a lot of it is related to that, more than sometimes even than just the technology. Of course, we definitely don't want our docs to become sort of the Apple Genius bars where they are helping the patients along. But there have been issues as well where providers have had to troubleshoot with the patients, whether it's, Bluetooth seems to be a really it's a challenging issue where patients forget they have their Bluetooth on, and then the voices, in their car parked in the garage and not coming on the phone, and they can't hear each other. So things like that, and how to, troubleshoot or over a phone. Just right now, when we were getting on the Zoom meeting, you guys had me as a participant and not a panelist, so you guys couldn't hear me. I had to, send a text. So those kind of troubleshooting things, but once you're set up, once you're in, it's pretty seamless.
No, that's great. How did UPMC Pinnacle get into telemedicine? I know that the hospital has been using telemedicine for some time before COVID. How did that start? What was their reasons and justification for that kind of expenditure?
Yeah, so we have been using some form of telemedicine here for over a decade. And just a historical perspective, telemedicine has been around for a really long time, especially teleradiology. And we don't think about teleradiology as telemedicine, but radiologists have been providing radiology coverage to hospitals wide and far for a very, very long time, from almost 50s to 60s, right? So we're talking about 50, 60 years ago, telemedicine has been in some form or shape. Here at UPMC Pinnacle, we have been using some form of telemedicine for almost a decade, and started around 2011, 2012. And it really started more of tele-stroke coverage across our hospitals as we grew. Originally, we had 3 hospitals, then we expanded to 7, and part of the larger UPMC system, which is across 41 hospitals. And all across UPMC, really tele-stroke was sort of, besides teleradiology, tele-stroke was really a sort of catalyst. As you guys know, stroke patients need care right away at presentation during the ED. And having a neurologist available via telemedicine that can see a patient and make those sort of life-changing decision related to their care was instrumental to get this started. So that was sort of our initial reasons and to get into telemedicine.
And now with the COVID virus, things have really ramped up with the need for telemedicine and its role in things like social distancing and changes in contact and remote monitoring, etc. How has the program changed since the very beginning of the outbreak. Let's call it January, into January. How have things changed recently, and what does that trajectory look like in terms of changing the technology and employing it differently?
Yeah, so I'll try to break it down in a couple of buckets. So I mean, it's really been a revolution. We just exponentially blew up telemedicine across the enterprise, from ED to inpatient to urgent care to primary care visits to specialties to virtual family visits, to ambulance care. Across the whole gamut, we have been delivering care, like you said, especially during the crisis, as patients stay at home, but still need the necessary care, still need to be seen by their doctors, still need their medicine. And it's been tremendous to have these platforms and have the providers ready to deliver care via this platform. So a couple of examples. I'll go back to mention our hospitals and ED. We started with sort of trailers to expand our ED capacity for the surge, and we had sort of telemedicine coverage from our ED docs in those trailers. Again, trying to reduce exposure, conserve PPE, which was a big deal for us initially. And same thing on the hospital. We started virtual rounds, so hospitalists, so your inpatient physicians, and I'm a hospitalist by background, so very near to that, as well as specialties, so our endocrinology, our other critical care. We were able to expand critical care across all our 7 hospitals with tele coverage, so sort of a second layer of eyes and ears to provide the necessary care for those COVID patients, as well as family visits in the hospitals. As you know, almost all the hospitals have restricted visitors, but it's important for us, for the patients' families and loved ones, to interact and to visit their family members in the hospitals. So we're able to set up family visitations via virtual visits as well. So that's sort of our inpatient ED realm. And then on the outpatient side, we're able to, we had to close several of our express cares, urgent cares, and transform a lot of those into virtual urgent cares, where we're able to screen patients for COVID or patients' concerns for COVID. If they're not seriously sick, they can be seen by virtual sort of care, virtual urgent care. And then same thing, online video visits for our primary care. So for existing patients that need follow-ups, need to be seen for their medical issues, whether it's diabetes, hypertension, medication refills. They can see their primary care, their annual wellness exams, that some of those can be done as well. And then specialty care. So some medical specialties tendered more towards telemedicine. So for example, rheumatology, endocrinology, neurology, cardiology, a lot of our, across 45 subspecialties have been delivering care. And it's not just medical specialties either. A lot of our surgical specialties also have been able to deliver care via telemedicine during this time.
Well, what kind of, just to get an idea of how much that COVID has really changed things, what kind of volume were you doing in telemedicine before, and now what kind of volumes have you done since this outbreak of the pandemic?
Yeah, so we have probably went up 1,000%, just volumes exponentially. Before the COVID crisis, we were doing handful of visits a day. And we had a handful of providers on the platform. When this crisis started brewing, we trained over 1,000 providers in just 1 week. We trained probably 2 times the staff on telemedicine. Since then, in just last few weeks, probably a little bit over a month and a half, we've seen 30,000 patients across UPMC. We've seen our delivered care via telemedicine to 250,000 encounters, or had telemedicine encounters, both again inpatient and ambulatory settings. And that number continues to stay there. It continues to sort of, we continue to deliver thousands of visits a day and every week. It's not something that's going away. It will probably dip a little bit as things start opening up here in Pennsylvania, but we feel that patients are getting used to it and are actually loving and enjoying this way to receive care.
Well, that's great. Are there age differences in using the telemedicine? Are people using it more or less differently in terms of young people versus old folks or parents? Or what kind of category use is there?
Yeah, so we always tend to think, that the younger generation would use telemedicine more than the others. But we have had actually several patients, over 100, use telemedicine. Now, of course, they're using it via the help of their family members or neighbor or loved ones, which is tremendous. So again, it's possible in any age range. Actually, our highest age group is between 51 to 60. It's not the younger crowd. So most of our care by telemedicine is delivered over the 50 age group, and 50 to 68 bracket being the highest utilizers.
Well, I'm sure you're getting some feedback from your patients. How do they like using telemedicine?
Yeah, so as I was sort of referring to earlier, a lot of these folks are consumers are getting, are used to some other form of sort of technology like FaceTime or some kind of video chat, and it's very similar to that. It's now just FaceTiming or having a video chat with your doctor. So our patients really love it. We are in a pretty wide geography. They are enjoying, they don't have to travel during this time. They are usually not having to wait as long in what they would normally wait in physician practices. And probably even if they are waiting, they are at home, so they are doing their regular things, so that wait time doesn't appear to be as bad as it might be. So a lot of patients are able to really appreciate the time saved and just still being able to see their providers during these tough times. So really positive reviews from our patients.
Yeah, I agree. It's nice to have the FaceTime or any other chat experience. But what kind of challenges are they facing from the use of telemedicine? Is there anything special about it, or is it just simply another Zoom meeting?
Yeah, so some of our patients, like I said, are new to it. They've never experienced this before. So they just like Zoom, you have to download something. You have to, get on our secure app, which is My Pinnacle Health. And once they get set up, it goes pretty seamless. They do have to do hardware and software tests. It's available. And we sort of use that airline or flying experience, so they can check in 24 hours before, and then they can do the video connection just like you board the plane, 30 to 40 minutes before. You can get in and get on the video 30 minutes before. That's something new. When you're coming into office, you don't think about, you have to check in 24 hours before. But for a online video visit or telemedicine visit, you sort of have to. You can do that. So it's a new way to receive care. But once they get used to it, they're liking it. There's of course, there's those patients that have challenges, but we have ways to work through that. We call our patients. We have a lot of online tutorials that we put out, so the patients can watch or just read through step-by-step instructions. which I think is huge, right? And with any new program or new platform, you know, as much it's good to provide as much help as possible. A lot of these folks are also figuring out how to do it. And then there's also sort of sometimes technical glitches, which will always be there. Like I said, right, like muting somebody and unmuting your phone, and you know, there's new softwares. Just right when the crisis had started, Apple pushed out a new upgrade to their iOS, and that was, you know, a lot of us have automatic upgrades, but sometimes we like to delay the upgrades. I am one of those. Sometimes, you know, I don't want to have any changes to my UI or changes to my you know, apps being changed up. So if they haven't updated their iOS, you know, there's always some glitches around that. So we have to call them and say, hey, you know, did you download the latest software? And then you know, usually we walk them through downloading that. So things like that, just normal technology challenges that you would experience with anything.
Wow. So let's shift over to a broad perspective. And what kinds of situations lend themselves to telemedicine?
Yeah, so that's a question that's been consistently discussed here, and you know, comes up every day. So we, you know, we think of telemedicine. It's just another way of delivering care. It's a platform you deliver care on, whether it's you get seen in an ED or in a clinic or in a hospital, or you get seen via telemedicine. The excellent quality of care that we deliver, it remains the same, right? So it's not different care. It's not substandard care or anything like that. It's the same level of care that we deliver, whether via this platform or this model of care versus somebody in person. Now, we think most situations, most specialties can lend themselves to the use of telemedicine. Primary care, probably more than primary care and medical specialties more than others, but we found that there are no limits to it. Like I said, we deliver care for sort of those emergent cases for stroke in our EDs. We deliver critical care in our ICU via telemedicine, both for not just physicians, but also for nurses to get a second set of eyes and ears. So there's, I think of it the other way, is there are only very few conditions that doesn't lend itself to telemedicine. And then in that situation, the provider or physician can make, at their own discretion, can sort of escalate the levels of care. Just like that, you know, I'm primary care trained. If I would see a patient in the clinic, and I feel like that's not the right setting, then I would escalate that to whether to an urgent care or to an ED or to sometimes, you know, a direct admission to the hospital because they're sick enough. It's the same thing by telemedicine. Some conditions, if we find that they are truly seriously ill and they need to go be seen at ED, we can direct them there. But again, most of the data that we've cited and our own experience, that's usually about 10% of the cases for especially on our on-demand settings. So or our online urgent care settings. So most of the patients that we see, 90 to 95% of the time, we're able to deliver care via this care delivery of telemedicine.
So it's a huge spectrum of problems and medical problems that can be dealt with. But are there situations that don't lend themselves to telemedicine use? You know, surgery notwithstanding, because it's difficult to do over a laptop. But given what the technology we have now, what kinds of things really don't lend themselves to telemedicine?
So that's, you know, surgery is a good example. I would think other areas that really need a lot of diagnostic testing in the clinic. So, for example, EKGs in a cardiology office, or a surgeon or orthopedic surgeon that needs to look at the X-rays before they inject the knee, or again, like a small procedure like injection of knee. Of course, can't inject over telemedicine, but sometimes they make the diagnosis using other tools that might not be available. Now there are a lot of tools that are coming online. So you can go buy like a self sort of home diagnostic kit that has otoscope, ophthalmoscope, a dermoscope. So patients can get some of those technologies as well, and we're pushing out that as well. So another excellent program that we have is for OB care. So for our pregnant patients, they can be seen at home, but we send them blood pressure monitors so that they have something to check their blood pressure and sort of report to their provider when they're seeing it. So when we find situations where we really want to deliver care via telemedicine, but it would be nice to have another additional tool, we're closing that gap. Some of the things that in our Western Pennsylvania market we're doing is sending patients home with pulse ox, especially those COVID patients that are not really sick, but we just might be a little bit concerned about sending them home, and want some of that extra layer of care at their home. We send them home with pulse ox so they can monitor their oxygen and report back to us. And that's seemed to work really well in terms of sort of closing those gaps where we might not have been able to a few months ago or even a few years ago.
Well, and I know in this environment today with social distancing and lockdowns at home, mental health issues are really coming up, with people being depressed and people being anxious, and a whole bunch of not the worst psychiatric disorders, but a lot of need for counseling and assistance. Is telemedicine turning out to be useful for that?
Absolutely. So before COVID, behavioral health was our sort of highest utilizer of telemedicine. As you said, a lot of those not serious but mild to moderate behavioral health issues such as depression, anxiety, a lot of times just counseling can be delivered via this, and also this removes a lot of sort of anxiety for patients as well to come to office and sort of be exposed around that environment. A lot of patients, believe it or not, felt more comfortable getting the care whether they're at office or in privacy of their home. So our highest utilizers were behavioral health. And we're continuing to see that trend right now as well. So a lot of patients accessing their counselors and their psychiatrists using this.
Great. And here in mid Pennsylvania, we have an awful lot of rural areas.
Mm-hmm.
Are there any real special challenges with getting telemedicine delivered to those folks who really would have to travel a long way to the hospitals, or is the technology up to it? How are you experiencing that today?
Yeah, so the technology is there, but that's where sort of we get into that digital divide of the ones that have broadband internet and the ones that really don't. And there's, like what we were saying earlier, right? For some of these patients, this just might not be the right platform. As in, if you don't have internet, it's a challenge. Of course, that's sort of at a country level, at a state level, we need to look at expanding 5G and expanding broadband access to some of those areas, and how do we sort of collaborate and work with some of our telecom companies like carriers, and how do we close that digital divide. So it is definitely one of those areas that we look at, we think at constantly, because we want to deliver equal care to all our patients. We realize sometimes that's difficult, but again, we're hopefully working to close some of those gaps.
Do you think 5G will make a difference in diagnostic ability or that sort of thing, or is it just going to be a more efficient picture? Do you think 5G will have a clinical impact?
I think so, especially on the inpatient side of things, where there are a lot of images that are being transmitted. So as I mentioned, sort of the telestroke. So our neurologists aren't just looking at the patient. They are looking at the patient, they're looking at the clinical picture, but they're also looking at imaging slides. And sometimes, believe it or not, some of our providers might not be in a clinic or in a hospital. They might be somewhere in the middle. And if they had 5G access, they could rapidly get access to those images, and it would make them a little bit more mobile than they already are. So there are some limitations besides just, of course, getting a nicer picture view, but 5G would open things up that we haven't even dreamed of right now.
So those of us physicians who spent a lifetime trying to keep up with the literature are now challenged with keeping up with the technology. I guess it is essentially a problem for small offices, individual practitioners, to try to keep up with this technology as it evolves and interact with more sophisticated technology, perhaps at the hospital and system level.
Yeah, and we have seen even during this crisis, a lot of the smaller hospitals have become innovative and are using it. There are a lot of national sort of organizations that have been supporting those. We have our partners as well, and we try to help them through it. We also deliver care to our critical care access hospital partners like Fulton County, and really try to be a good partner to our community members, providers, clinics, to help them guide through if they are getting sort of stuck or need help on how to deliver it. But we've seen a lot of practices go out this route.
Well, I'm going to try to find a silver lining in the coronavirus. And I'm thinking, if this hadn't occurred, this pandemic and all of these challenges that we have in clinical medicine because of it, I'm not sure where telemedicine would be, what the trajectory difference would be. And do you agree that that this COVID virus pandemic has been a real catalyst for getting telemedicine where it might well deserve to be?
Yeah, absolutely. So I think this is one of the silver linings for sure. This probably put us at least 10 years ahead at what we're seeing right now. It's yet to be seen how things will change once sort of the crisis calms down a little bit. COVID is not going away anytime soon. It will be in our communities for a while. And sort of some form of social distancing will remain. And we have, like I mentioned, we have really revolutionized medicine. Usually after a revolution, it's hard to go back for everyone, for the providers, for the patients, and for even the insurance companies. So I know that CMS is looking at it. CMS sort of administrator, Seema Verma mentioned recently, genie's out of the bottle. It's going to be difficult to get it back. It's going to be a sort of a different world. We don't know what it looks like, but it's definitely going to be some form of telemedicine that's widely used.
Well, then I'll get to my key question here as we get toward the end of this webinar. And that is, where do you see telemedicine in 5 to 10 years? What's it going to look like?
Yeah, So I wish I had my crystal ball, but I think it's going to even get more widely accepted and just become routine part of care. So almost as, you know, we don't even think about clinics or delivering care in a hospital or an ED. It's care is care. Medicine is the way we practice medicine. I think it's going to get at that level where telemedicine is sort of just becomes embedded as part of the health system. Um, it the technology, 5G and other platforms, the companies are going to have to rapidly innovate um, and find tools and expand the use what we are currently seeing. Um, I think there's a lot of potential. Um, you know, some of the things, you know, I'm thinking about is sort of closed captioning, right? So technology is there, such as Alexa and other Siri, where if we're talking, there should be a closed captioning happening right now instantaneously. That would be huge for those patients that are hard to hear or plain deaf, right? It's really difficult, right? Unless you get like a sign language person right next to you, which, you know, not a lot of us have that easily accessible. Um, a lot of we were discussing forms and scanning of the forms and things like that. So currently the patient has to scan something and send it to their providers. Can we make that easy? Can we use the you know, cameras that the patients have? A lot of wearables are coming into markets. A lot of these patients, right, have now a smartwatch and it can diagnose AFib. What's coming next with those? So right now you can, you know, diagnose some form of arrhythmia. So a lot of that is going to sort of start getting embedded and expand and really enhance, I shouldn't say expand, but enhance the experience of telemedicine. And it's the same thing as providers get used to it and as patients get used to it. I know they're going to demand it. People are not going to want to keep driving 1-2 hours, especially in our areas, as you mentioned, a lot of those rural counties which that they don't have a specialist or a clinic or even a hospital around in the neighborhood, or they're going to look at is it, you know, worth having to drive. So I think it's going to get even more widely accepted, and there are care models that are going to come out that will sort of enhance what we currently already do.
Great. Is there anything you wish I'd asked you?
Um, I think again, the point that I made earlier is that telemedicine is not any different. It's just a care delivery model. It's not a different or less care or substandard care. It's just a care delivery model, just delivered via a telemedicine platform. It's the same excellent care. We're the same providers. My medical knowledge, the way I can do things, whether you know, prescribing or ordering tests or anything like that, I can do that. Yeah, one more most important thing that a lot of people don't seem to think or think it's a myth. We can do a physical exam as providers, as you know. As physicians, we can do a physical exam looking at a patient, guiding the patient through a physical exam. We teach some of those salient features on how to do that as well. We actually get a lot of information by looking at a patient's home environment, looking at their family, getting their families involved. We find a lot more. So yeah, physical exam is possible. That's just one thing people or patients sort of sometimes forget. We don't necessarily always have to listen to your heart and lungs. I know this is sort of the tradition, and that's what, when you see a doctor, you see a stethoscope, and that's, I should have probably put a stethoscope for this interview, but you think about the stethoscope, and that's like the cornerstone, right? That, okay, you need to listen to heart and lungs. Not always. Actually, not many times we don't have to. So that's one thing I think that we didn't discuss, but it's really important.
Salim, thank you again for being with us for this webinar, and we really enjoyed your experience and your expertise. Again, for our audience, this has been Salim Saiyed, a physician and fellow board member of Central Pennsylvania HIMSS and VP in Systems CMIO for UPMC Pinnacle here in Harrisburg. Salim, thanks again. We really appreciate it.
Thank you, Glenn. It was an honor.